I'm Dr. Peter Lundberg. I'm one of the chief surgery residents at Tulane University Medical Center in New Orleans. I'd really like to thank the committee and SAGES for giving us the opportunity to present our work. I have nothing to disclose. So, achalasia, the infrequently seen but oft discussed disorder of esophageal motility, involves two main points: impaired peristalsis of the esophagus and a failure of the lower esophageal sphincter to relax. Surgical treatment of achalasia really only focuses on the latter, and it is palliative in its treatment thereof. This does not treat the underlying cause of achalasia. Diagnosis, gold standard, is via manometry, though esophagram and upper endoscopy are also useful. Medical therapies have been shown to provide limited relief compared to surgical options. Botulinum injections are usually reserved for the most critically ill of individuals and have long been proven to be not cost-effective, while pneumatic dilatations require repeated procedures and carry a higher risk of esophageal perforation. As such, myotomy provides the most durable treatment. At present, there are two commonly performed surgical myotomies. The standard is the laparoscopic Heller myotomy, the open version of which was introduced by Dr. Heller in 1913, and it is always paired nowadays with an anti-reflux procedure, usually a door fundoplication. This nonetheless results in reflux rates of 20 to 40% postoperatively. The novel approach, which has been discussed at length at this conference, it's been very exciting to see, is the peroral endoscopic myotomy, first performed on a human patient in 2008 and published in 2010 by Dr. Inoue out of Japan. It was performed through a submucosal flap and without any incisions at all. And their series has now well exceeded 1,000 patients. And even though it does not include an anti-reflux procedure, it demonstrates similar post-procedural reflux rates, just thought largely due to the fact that only the circular fibers are cut, not the longitudinal. The current background into POEM in the last couple of years has been really exciting. Chua et al. Really firmly, in their review, demonstrated POEM as a promising alternative to conventional laparoscopy. And in 2013, the ASGE and SAGES white paper demonstrated a better length of stay, operative time, postoperative pain, and time to recovery for POEM. In 2015, a randomized trial comparing laparoscopic Heller myotomy to pneumatic dilatation also supported a myotomy over a less invasive procedure, despite initially high comparative cost. And then in 2016, a group out of Cleveland demonstrated cost equivalency between POEM and Heller, notably with a similar length of stay for each. It was a very nice paper. Our technique is pretty standard. Our POEM is done the same way as described in most descriptions, and most of what is being presented here, as is our Heller myotomy. As far as our patients, all of them undergo standard preoperative testing, including manometry and esophagram and upper endoscopy. In our practice, patients who have clinical reflux or evidence of a hiatal hernia on preoperative evaluation are excluded from consideration for a POEM. That is a noted limitation of our study. But our design, given the continued classification of POEM as an investigational procedure and findings from other institutions that this may be cost equivalent or at least, or perhaps cost effective, we wanted to look solely on the cost of the actual procedure. And so in the prior 18 months, we performed 13 Hellers and 8 POEMs. As you can see, as far as comorbidities and demographics go, they were not significantly different. In our analysis, we did see a significant cost benefit to POEM, particularly manifested in a decreased operative time and decreased direct cost, that is, cost directly related to the procedure. Notably, this cost analysis is limited. We were treating these as nominal data, just doing t-tests, and we did not break down into quality of life scores that incorporate considerable follow-up that a lot of predecessor literature has performed. Additionally, these data were provided using our hospital ownership's proprietary cost reporting data, using the Crimson database. And they broke it down into total cost, not total charges per the admission. As I said, this is a limited study in that it is a single center. We do have our single operative approach and a unique cost assessment. Also, with only a total of 21 patients, power is an issue. Certainly, if we were higher powered, you might even start to see differences in length of, significant differences rather than trends in both length of stay and variable costs. And additionally, it is also non-randomized, which proponents of POEM over a Heller long to see the randomized controlled trial that might push that minimally invasive procedure into the gold standard position. And that's really what is going to be needed going forward. In addition to replication of findings just showing a cost effectiveness of a POEM over a laparoscopic Heller myotomy, we need randomized controls. In addition to that, we hope to see in the coming years improved insurance coverage and reimbursement as this becomes repeatedly demonstrated as a safe and efficacious procedure. Additionally, there are some groups, notably in Oregon, who are experimenting with same-day discharges after a POEM, with or without post-operative swallow study prior to reinitiation of oral feeding. There's actually a clinical trial recruiting for that right now. Additionally, there's a lot of centers performing POEM not just as an index procedure, but as a revisional procedure both after a POEM and after Hellers for incomplete myotomies. That's my references, and I just wanted to thank the committee again and all of you for listening to me present our work.